got it. Okay, so let's continue. So we have, there is some differences between a adult female and adult male. So it's a little bit lower. That's why we have between 60-65% in the mid-age. And but average for both genders, we are going to still using 60% of the total weight. All right, so let's keep going. So we have here the total body weight from the. This is the total. Just a moment. From the total body weight, we have 2/3 of that is going to be the intracellular fluid. Intracellular fluid. So 60% of all this is going to be in the intracellular fluid, and 33% is going to be in the extracellular fluid. So everything outside the cell is going to be extra, and all fluid that are outside the cell, we divided or we differentiate between interstitial and intravascular. So interstitial is the fluid between cells, and these are going to be composed 75%. 25% is the vascular, intravascular. So that be about 4 to 5 liters, 4 to 5 liters. So you multiply by 3, that is the amount of interstitial fluid. The summation, the extra, and that is 30% of the intracellular. All right, so we already know about the major cations and anions outside the cell or inside the cell. That is going to be important to understand how is the reabsorption of the substance in the kidney. Extracellular fluid is composed by plasma and interstitial fluid. We have the plasma. The plasma is going to be 1/4, 25% of all the extracellular fluid. Okay, so I think this is something that we already know and review. If, for example, if you have isotonic fluid, if you have an isotonic fluid added into the bloodstream, there is no different of charges. So there is no gradient. Sorry, there is no different of gradients. So that means that that there is no exchange of water. So it's not coming in, it's not coming out, because the amount of the osmolarity that we have in blood is about 250 to 180 millimoles, and that is totally actually equal concentration outside. So there is no changes of fluid. If we add isotonic, if we lost isotonic fluid, that is going to be loose from the extracellular fluid. So what happened here is in this isotonic fluid you're going to lose is what we call the MO concentration, the MO concentration. So the proteins are going to increase in concentration, not because we have more concentration of proteins, is because there is less fluid in the blood. The same with if we infuse isotonic fluid. If we infuse, is what we call the hemodilution. Some patients who coming some bleeding, it's important because if they are bleeding, they give some fluid, and this fluid is going to dilute the number of red blood cells, and and the opposite. So that's when it's happening, infuse and or lost isotonic fluid. Administration of sodium chloride, that is where it's going to increase the sodium and chloride in the extracellular. So we have hyperosmosis, hyperosmotic volume in the outside. So in this this part of the lecture is talking about isotonic, hypertonic, and hypotonic. I make remember my students in the classroom is that, for example, hypoosmotic, they are going to, or hypotonic, sorry, hypotonic, they are going to create the cell like hypopotamus, like it's going to increase size. So hypotonic, hypopotamus cell. So what does mean? That the water is going to get into the cell. And if we have hypotonic, the hypertonic is going to be the opposite of the hypotonic. Okay, so let's go over other functions of the kidneys. We have activation of the vitamin D. We have two sources of vitamin D, diet and the skin. And the skin is giving us a vitamin that is not activated until they go to the kidneys. So that's why people who has problems with chronic kidney diseases, they have some kind of they have what we call some kind of loss of mineralization of calcium in the bones in the long run because they cannot activate the vitamin D in the kidney. We have the production of renin. The renin, some books talk about this as an hormone. Some other books talk about as an enzyme. In this book, I think they are talking about this as an hormone. We have the erythropoietin that is produced by the cells, cuboidal cells of the convoluted, convoluted tubules. And that is stimulated by the low levels of oxygen in blood. So hypoxia is the one who stimulates the secretion of erythropoietin from the kidney. So, and this erythropoietin produces more number of red blood cells. Electrolyte balance, we already, well, this is actually electrolytes, mostly water that is going to reabsorb according to the needs of the system. Waste elimination is important because we have the product that is the urea that is coming from metabolism for the proteins, ammonia go to the liver changes to urea is going to eliminate it. Another thing that we need to remember is that waste elimination is used for when you take medication. When you take medication, it's always is recommended to take more fluid because the pharmacos are going to lead into some toxic substances. They're not using all the medication. This being medication metabolized by the liver, and the metabolites results of this metabolism are going to make the effect that we want, therapeutic effect. But there is another part that will be toxics, and these toxic need to be eliminated. One of the ways is the kidney. Gluconeogenesis. Gluconeogenesis is going to be the formation of glucose from other sources that is not sugar or glucose. And this is one of the functions of the kidney. The kidney is besides glyconeogenesis is going to have the glucogenolysis, and that is coming from the kidney itself. Okay, so let's talk about the renal clearance. Clearance. What is clearance in few words? The clearance is, I compare always the kidney as a vacuum. The vacuum is going to vacuum dust. If we have some amount of dust, that is going to absorb without no problem. But what happens if we put like 20 kilos of dust in front of the vacuum? The poor vacuum is not going to able to absorb probably everything. It's going to not able to vacuum as a small amount. So the same is with the kidneys. The kidneys are the vacuum, and the dust are going to be all not necessary waste products. Only glucose, but amino acids too. So, for example, sugar, glucose, diabetes. If we have some amount of glucose in the blood, the glucose is being absorbed by the kidney. It means like the vacuum is going to absorb everything. But if you have excess of glucose in the filtration, they are not going to be able to absorb. It's like the vacuum trying to do extra job with a lot of dust. So the renal clearance is the ability of the kidneys to clear substance out of the blood over a period of time. So we have clearance, renal clearance is, for example, we are going to talk about the glucose, the inulin, and those are substances that are going to help us to measure the clearance. So clearance is, there's a formula here. We have the urine flow rate We have the volume pressure with here the clearance. So I'm not going to go into the formula. I think it's not going to be useful for us, but definitely renal clearance is the way how we can measure how the kidney is working. Creatinine is a substance produced by the muscles. It's a metabolism of the muscles, and they are going to as much they're all mostly creatinine is going to be eliminated by blood. Why we are talking about creatinine? Creatinine is a waste product of the metabolism of the muscle, and this creatinine is going to be having certain similar levels every single day. This creatinine mostly is going to be eliminated everything on the kidney. So creatinine is for us almost a constant number unless we have a trauma or we do excessive exercises in one day. The creatinine can go up because it's coming from the muscles. So there we have here, therefore, the creatinine excreted is the same as the creatinine that is filtered. All right, so to check renal functions, we first of all we need to see how the kidney is going to receive blood flow, and another thing is to check the ability of the kidneys to remove waste products from the plasma. I tell my in classroom I tell a word like I call fresh F-R-E-S-H, and fresh is the mnemonic that I use for the functions of the kidney. Fresh kidney is F filtration, R reabsorption, E elimination or excretion. I told them what is the difference between excretion and secretion. So we have fresh, filtration, reabsorption, excretion, secretion. Secretion of what? They are going to secrete bicarbonate, for example, or hydrogens. Hydrogens are going to be secreted. They are going to be secreted to the some medications. And H is the hormones. Hormones, I include here the erythropoietin, I include the renin, and yes, a tip more, I always mention the vitamin D. It's a vitamin, it's a hormone, but in the mnemonic it doesn't have place. But it's all the functions of the kidneys. And in this class, they want to check how is the perfusion of the kidneys and how the kidneys are removing the waste product. So this is mostly clearance, and this is the perfusion that we are going to calculate that. So clearance is, the units are mLs per minute or mLs in 24 hours. So another substance that we are, so yes, remember that uh, know the function of the kidney, we know that the creatinine is constant, almost a constant number in the body. So it can help us as a standard to compare the creatinine excretion or clearance of the creatinine in order to know how the kidney is working. Then we have the para-amino hypuric acid, the PAH, and the PAH is actually similar as the creatinine. This pH is not produced by the body; is administered to the patient. And what is characteristic of this pH is can be filtered and secreted by the renal tubules almost 100%. So what you give to the patient, what the patient is taking away in the urine, so calculating that, you can tell how the clearance how the renal clearance is working. So there are some formulas here that they actually what they are trying to do is how much coming in, how much is coming out, and the result should be that equal number. So how the amount is coming into the system and the amount is coming out from the system should be the same in this case. The inulin is another substance that are going to be used in order to do the same type of calculations. All right, so let's talk about the Starling forces. And the Starling forces is this is a capillary. Let's imagine that is the glomerulus, and inside we have red blood cells. We have all the we have water, we have all the nutrients, etc. And this fluid inside this capillary is going to create a pressure. This pressure are going to make the water to make happen the filtration. All right, so just remember that these capillaries in the kidney are going to have some pores, some openings, and this glomerular capillary, because of the pressure inside the capillary is going to make the substance and water come out from the glomerulus to go into the Bowman's space. Bowman space. All right, so we have two forces. We have the hydrostatic pressure and colloidal osmotic pressures. So hydro, water, colloid is related in this case to proteins. So proteins love water. Proteins are going to make the water follow proteins, and if we have good amount of proteins in the bloodstream, the proteins are going to hold the water into the intravascular. So if that is going to hold, for example, proteins, they are going to the net pressure of the fluid inside the capillary bed is going to be basically on the hydrostatic pressure. So the pressure of the water against the wall of the vessel minus something that is retained in the water, so it's totally in opposite direction, will be the proteins, and that is what we call the colloid osmotic pressure. Okay, so all right, so let's keep going. So this is the same thing here, the capillary pressure. We have the plasma colloidal osmotic pressure that is given by the proteins. Can you see here? This is in the direction towards the wall, and the colloid osmotic pressure of the proteins is the opposite. So if you subtract this from this, that is going to give you about 8 to 10 millimeters of mercury positive. So that means that is the pressure how the substance are going to go out from the capillary into what we call the ultrafiltration of the kidney. All right, so that is about this. I want just to go over the reabsorption of substance. That is really interesting, and but definitely we need to go a little bit in detail here. All right, so everybody knows about the importance of the sodium. They are going to be part of the depolarization or contraction of the neurons, muscles, the three type of muscles: cardiac, skeletal, and smooth muscle. So sodium, in addition, is going to water is going to follow sodium. Water follows sodium, and there we are going to see how sodium is going to help in order to reabsorb glucose, amino acids through the membrane, because there is transporters that are going to be working with sodium. So those are actually just a summary of the sodium. All right, so here we are going to have, so this is all the glomerulus, the nephron. The nephron up to here, this is the distal convolute tubule. Here is the collecting ducts. This portion is not a nephron anymore. It's called the collecting ducts. And we see a line here. This is the line. This line is between the cortex and the medulla. This is very important in order to understand how the reabsorption is going to happen. Especially here, first of all, we have the PCT, we have Lux Henle, we have the distal, and the collecting ducts. This line, just not to lose the momentum, I want to say that this medulla is is more salty. It's more, it's having more high content of sodium in this medulla. In the cortex, no, it's having is less salty. Why the medulla is more salty? Simple. Why? Because the ascending, I didn't say descending, we said the ascending loop of Henle, they have what we call this sodium potassium ATPase pump. This sodium potassium ATPase pump mostly are located here in the ascending limb of the Henle's loop and in the proximal convolute tubule. But here is what we saw in the previous class, in the first class, lecture number 1. So if here we have ATP, sodium potassium ATPase pump active, so he doesn't care about the gradients. He's going to take sodium from the cells of the duct into the interstitium here. So that is going to be in purpose. So they are going to have high gradient or concentration of sodium here, less concentrated in the walls of the cells of the Henle loop, and high concentration here. So besides that, they're creating that difference between gradient that is going to suddenly make the sodium go spontaneously into the cell and then into the lumen, because the sodium is going to follow water. One thing we want to know is the 60% of the reabsorption are going to be in the proximal convolute tubule. Here we have here in the descending limb of the Henle's loop, they are going to have, there's permeable to water. This is permeable to water, and actually sodium is not that permeable. But here is the opposite. Here the water is not permeable, so the water cannot get in, cannot go out, but the sodium potassium can pass easily. All right, so here we have the active pump sodium potassium creates a low intracellular. So this is the PCT cell. This is the blood, and this is the lumen. So the pump sodium potassium ATPase is this pump that what it's trying to do is taking out sodium from the cell into the blood. So what is the resultant of this? The resultant of this is that they are going to have low sodium in the intracellular. So in comparison to the lumen, in the lumen we are going to have, in this case, high sodium because it's coming from that filtration, high sodium, and they found this area that have low sodium. So high sodium in the lumen, where is the urine, where is formation of the urine, and inside is low sodium. So what happened? Sodium is going to pass to the cell, and when the cell is going to pass, when the sodium pass to the cell, that is going to be followed by water. So more sodium, more water retention. Okay, so that is about the ascending limb. The furosemide, what they are going to do when you lose sodium, when you reabsorb sodium, you're going to furosemide inhibits this pump, and what happens is that you are going to lose sodium and you're going to lose potassium in Lasix, for example. All right, so let me see. So in conclusion, the most important thing about this lecture is just to remember the sodium potassium ATPase pump. This is the one who is going to make really sodium carry water or not into the carry water into the cell. So if we inhibit this pump, that is what happened when we do some Lasix. They are going to just the Lasix, what is going to do is to make you lose sodium and potassium. Well, okay. So let me, Joe. You know what? Let me close first this. Let me. How I can stop the. Uh, just a moment, please. I want to talk to you.
Can you still hear me?